Hello and good day to you all. Navid from Edinburgh Endodontist here. Hope you're all well and welcome back to those of you who watched the first episode of these lectures yesterday. I hope that you found them useful. Today, I'll cover enamel fractures. As you may recall, we are covering dental trauma over 2 weeks, one type of injury per day. We are splitting them into fracture injuries and luxations. So this week we are doing fracture, next week luxations. And yesterday we started with infractions and today is the enamel fracture. Yesterday we discussed the aims and learning outcomes. So I'm not going to go through them again. It's the same. And also we talked about the importance of time in prompt and appropriate management of traumatic dental injuries. We also talked about the etiology. For those of you who missed yesterday's lecture, you can find it under infractions. And please watch that as well, and preferably first before this one, because we're going to start from the easiest and go step by step to the more difficult ones. So this week we will cover fractures, and today we'll go through enamel fracture. Enamel fractures are defined as those in which an enamel is broken off the tooth with no visible sign of dentin exposure. So this, in a way, really depends on how much enamel you have to begin with. In a young tooth, you can get a large sort of chunk off without dentin exposure, but in a worn dentition, you may already have dentin exposure even without any trauma. So age and tooth were important factors here for diagnostic purposes. Clinical findings include an asymptomatic tooth, no tenderness to touch, no mobility, maybe a wee bit sensitive to temperature. Radiographic examination, again, should be unremarkable like infractions, but again, thorough examination is crucial. Please look at everything. Have it done systematically so that you won't miss anything. I suggest that you have like a flow chart so that you can just tick boxes as you go through them. And look at all the teeth. Don't look at the one that is just chipped. If you suspect luxation or displacement, take an upper occlusal, which can help you in diagnosis. I mean, one thing you need to look out for and ask for in the is the broken bit of the tooth. Ask the patient, they usually bring it with them, but if not, ask if they found it or seen it. Then, even if they have it, look for soft tissue lacerations as part of your systematic clinical examination. And cut, especially the lips, even if the fracture bits are found, it's very important. These lacerations usually have the bits in them or debris, so it needs to get cleaned up before being sutured. To check the laceration and rule out the presence of these fragments and bits and debris, if you dial down the exposure to 30 to 50% of a normal anterior PA sort of exposure and take a radiograph, you will be able to detect these fragments. If you have found the fragments, you must remove it before they cause scarring, because these fragments can cause capsulation and scarring if they are not cleaned out. You may need to refer to an oral surgeon if you're not comfortable with the removal of management of these lacerations. Okay, so don't feel that you must do it. If you can't, if you're not happy, it's better to send it to someone who knows how to manage these soft tissue lacerations. Now, this slide provides a good example of soft tissue radiography and detection of the fragments. In the first close-up photograph, you can see the lower lip laceration and the enamel fracture. If you look at the upper incisor, you can see that a bit of it is chipped off, and on the lower lip, you can see the laceration. Now, sometimes you may be able to see a bit of tooth poking out, but it's better for documentation to take a photograph and also take a radiograph. And to be able to take a radiograph and actually see what is going on, you can actually, in the second photograph, see the correct positioning technique required to look for these sort of fragments. You dial the exposure down to 30% or like 30 to 50%, get the patient to pout and hold an occlusal film opposite the tube and stay still, and then expose. So the patient will hold the film. You should know, or your nurse should not hold the film. The patient will hold the film. And then you can see that on the radiograph, if there are bits in it, in the lip, you'll be able to see the fragments, which is sort of a radio opacity or multiple radio opacities. And then you need to remove them or refer to an oral surgeon so that it can be removed. Now, the management in primary teeth, it's just, polishing up the rough bits to prevent trauma and reassure the patient and parents specifically. But in permanent teeth, if you have the broken bits bonded to the tooth, but sometimes you've got multiple bits or very tiny bits and you cannot sort of work out the jigsaw puzzle. In these sort of cases, just restore with composite, or if they're very tiny, it just polish it up. You may not even need to do any bonding. And monitor like infractions on an annual basis, clinical sensibility and radiographic. Okay. So to sum up, yesterday we discussed infractions. So the treatment for secondary teeth is just to reassure patients and follow up annually. And in enamel fractures, smooth, small sort of fractures. But if you've got larger bits, either reattach or build up. Then follow up annually. Check signs and symptoms as discussed yesterday. So sensibility, pain, swelling, discharge, mobility, perio assessment, periapical signs, and etc. So that's it for today. Then for enamel fractures, I hope you found this helpful as well. Tomorrow we will go through enamel dentine fractures, so things are getting a bit serious and juicy now. Again, please check Dental Trauma UK website. It is a charity to promote the best management of dental injuries to save teeth. Become a member and enjoy the benefits. Also, come back tomorrow to check the next lecture on enamel dentine fractures. Stay safe, take care, bye for now.